Hola, ¿qué tal? Es un gusto estar en esta charla en la que hablaremos de algunos temas relacionados con el paciente hemipléjico y con daño cerebral desde el abordaje fisioterapéutico. Mi nombre es Elvira Sarre, soy fisioterapeuta en neurodesarrollo y a nombre de RIE, Centro de Rehabilitación e Intervención Especializada, les doy la más cordial bienvenida. Gracias por acompañarnos. Es también un enorme gusto para mí presentar a Cathy Hazzard, amiga y colega desde hace muchos años. Voy a permitirme hacer un breve resumen de su currículum. Cathy es fisioterapeuta, tiene más de 32 años de trabajar con pacientes adultos con variadas condiciones neurológicas. También tiene una gran experiencia en educación clínica, en educación en el área de terapia ortopédica y terapia manual. Ha sido instructora y coordinadora de cursos para adultos desde el enfoque de neurodesarrollo desde 1998, impartiendo estos cursos certificados tanto introductorios como avanzados en toda Norteamérica y a nivel internacional. Vaya que ha viajado. Ha estado en Irlanda, Qatar, Hong Kong, Singapur, Estonia, Perú, Colombia e India. También en México, pues tuvimos la fortuna de tenerla aquí con nosotros hace algunos años, impartiendo este curso certificado a mexicanos y extranjeros desde el enfoque de neurodesarrollo para el abordaje del paciente adulto con hemiplegia y condiciones neurológicas. Gran parte del personal de RIE fue certificado en este curso para la atención de estos pacientes. Cathy actualmente trabaja en la práctica privada y en un consultorio en un lugar maravilloso en la isla de Vancouver, en la provincia de Columbia Británica, en Canadá. Ha sido conferencista también en los congresos anuales de la Asociación Americana de Neurodesarrollo. Asimismo, ha ocupado diferentes cargos en esta asociación. También es autora de 2 artículos para la revista Synapse de la Asociación Canadiense de Fisioterapia y es coeditora de un libro de neurodesarrollo que fue publicado en el 2016. Cathy, gracias nuevamente por tu generosidad y con tu contribución y tu deseo de estar aquí con nosotros. ¿Por qué es tan importante? ¿Por qué nos es tan importante este tema del adulto con enfermedades cerebrovasculares? Si vemos un poquito de estadística, la OMS nos dice que las enfermedades cerebrovasculares representan, fíjense, la segunda causa de muerte en el mundo. 1 de cada 5 casos muere y 3 de cada 5 quedan con alguna secuela. Si llevamos esta información estadística a nuestro país, pues nos damos cuenta que este es un problema de salud pública importantísimo. El doctor Adolfo Leiva Rendón, quien es director médico del Instituto Nacional de Neurología y Neurocirugía Manuel Velasco Suárez, nos dice que se presentan 170,000 infartos cerebrales anualmente, y siendo esta la primera causa de discapacidad de nuestro país, con el consecuente deterioro funcional y el detrimento en la calidad de vida. Es por eso que, frente a este problema tan serio de salud pública, tanto a nivel mundial como en nuestro país, pues RIE, desde el abordaje de la fisioterapia neurológica, se preocupa por mejorar constantemente la calidad de atención a sus pacientes y brindar una atención que incida en la calidad de vida del paciente, en las actividades que puede realizar y sobre todo en su participación social. Ahora vamos a cambiar al idioma inglés. After this introduction, Cathy, I would like to start talking about this moment, which is very crucial for us, where we first meet our patient. And sometimes we feel overwhelmed facing all these kind of impairments. We see asymmetries, we see movement disability, we see sensory loss, we can see speech problems, we can see problems with planning and movement. And we feel like sort of overwhelmed, and sometimes we can get lost in this trial. Could you give us an idea how to start observing, and what do you do to first get in touch with the patient and start finding or making hypotheses about his impairments, his or her impairments.
So, primera, buenas tardes, todos. That's all my Spanish for now. Now I'll switch to English. I think you're right, Elvira. I think when we first see a patient start to move, you know, or we start to introduce ourselves to them, it can be very overwhelming. There's so many things. Our eyes go to the head, to the trunk, to the arms, to the legs, and we see all of this dysfunction and we don't know where to start. And I think one of the things that's helped me through the years is to just back myself up and to keep it simple. I think that if we try to make it so complicated at first, we really won't be able to help them. So we need to definitely keep it simple. Are you going to be translating as I go, Elvira, or do you want
No, it's going to be translated later.
Okay. So I think what can help us the most is thinking of starting from the top down. And when I mean the top, I don't mean the top of the body. I mean from the top of the person. So using the ICF, the International Classification of Functioning Disability, is we need to find a few activities that are important to them that they can at least start to show us. So I really just ask for them to move in whatever way they can. Maybe it's something simple like picking up a glass, grabbing their jacket, standing up. And therapists are very good observers. We're the best observers out of the whole healthcare team. And I think we just need to use our eyes, and we need to think with our eyes, and we need to just kind of make mental notes of everything that we're seeing. So we look at those malalignments. You said we see these malalignments. It might be motor planning issues. But at this point, we're simply just making observations. I think that we need to not jump too quickly to thinking that we know what it is. Just make observations. Oh, they don't put weight on this side. Oh, they're not using that arm. Oh, they seem to not feel that foot because they continue to roll on. Simply just make the observations and look for the common observation. So what do they tend to do over and over and over again? What seems to be the movement tendencies? So we start to just make these observations and look for things that happen frequently. Does the hip always stay in flexion? Do they constantly stay to one side? Are they looking towards one side? And then you ask that question, why? Why are they doing that? What could the possible causes be? Again, I think therapists, especially physiotherapists, are so eager to get our hands on. I think one of the benefits of the pandemic, I'm always looking for the optimistic part of things, is that we can't get our hands on right away and we can't try and fix it. We have to not make assumptions. So make those observations, and in your head, make up that weakness in the antagonist. Are they not feeling, proprioceptively what they need to do? So you make a list of possible impairments, and then we have to test them. That's the next thing, is we have to test them by, I call it ruling in or ruling out. Mm-hmm. For example, if we see that the person never moves into dorsiflexion at the ankle, well, we can't assume it's tightness of the plantar flexors. We have to first test, is it weakness of the dorsiflexors? Is it a sensory impairment? Is it a visual perceptual impairment? So we have these possibilities, and then we simply test it out. And we test them out by constraining the environment, perhaps, picking different activities. I ask my patients to move through as many different activities as I can safely. I might need to put my hands on to keep them safe, but I ask them to move in as many different ways as I can, constraining the environment or picking a different task. It might have to be a little harder. It might also have to be a novel task, something that they don't already have a pre-recorded way of doing it. So something that makes them, if we're wanting to see if the arm moves, we have to give them a task that demands two arms. If we want to test how they actually stand on the one leg, then we have to take the other leg out of play by stepping up high onto something or kicking a ball or doing something that helps us sort out what it is that we're seeing. when we start to test these, rule in or rule out, if the impairment is real, we want to get down to, and this is kind of going on to, I think, one of the next questions you had for me, but you want to go to the top 2 or 3 maximum. One of the other questions was, how do we prioritize? We're seeing all of these things, and how do we prioritize? You want to go to the top 2 or 3 maximum, and I call these the most significant or tier 1 impairments, the top 2 or 3. And they may not have been the first one from the stroke or a brain injury. It might be one that's now a very secondary impairment. Maybe the ankle is so tight that if I don't fix that first, I can't get up to the hip, or I can't get up to the trunk. I think traditionally, neurotherapists have always focused on the trunk, as we've got to start with the trunk. And sometimes it's the foot or it's the wrist where you have to start. So you want to prioritize these top 2 or 3. The way I think about it is I kind of ask myself 2 questions. What do I have to treat first so that I can get at the other ones? And again, that's, it might be a secondary impairment. The other question that I ask myself to help me prioritize is, what 1 or 2 things, if I could help make better, would have the biggest influence on them functionally? So it might be great if someone could move their arm really high, but if they don't have a wrist that moves because it's stuck from a tightness or weakness of the wrist extensors, so who cares if the shoulder can move great if this is not going to allow them to use the shoulder? So those 2 questions that I ask myself is, what 1 or 2 things, if I make better, will help them functionally almost immediately? And then the other question is where do I have to start so that I can get at this other group of impairments? Because our patients, you're right, they have many impairments, 20, 30 impairments if we make the whole list. So we need to really focus and keep it simple at those top couple. So I'll stop for a second in case you need any clarification or get on that.
Well, I like hearing this, keep it simple. And we do have to be very good observers, but also we need a lot of creativity to challenge the patient in different tasks, different levels that really make them integrate the whole body. So I think you touch very good information and set out like 2 main impairments that probably affect many, many functions. So once you prioritize these impairments, I understand the next step will be to design the plan of treatment, or to design strategies, treatment strategies that cover maybe not 1, but many impairments. Mm-hmm. So what is your criteria to design or to establish these strategies to cover most of the impairments as possible, the most of them?
So I'm going to answer that, but I'm going to pick up on a couple of things you just said from the first question. Is I think that therapists lock ourselves into traditional ways to assess. We have set things. I need to see them walk forward. I need to see them climb a set of stairs. I need to see them stand up. And those are all fine. But I think sometimes what we have to do, when you said we have to be creative, is I don't think we have to be as creative, except for stop thinking so rigidly like a therapist. Is I think we have to let go of some of our recipes of we have to do A, then B, then C, and test things in a certain way. So let the function and let your patient's functional interests direct you. But also sometimes maybe mix it up. So let's say you're trying to assess how they move on their feet. We always think of walking forwards and going upstairs. But that's the word, that novel thing that we talked about, have them walk backwards, because walking backwards might show up some things or help you rule in or rule out some different things. Walking backwards requires the hamstrings much more. Maybe if I have them go backwards, I might see, are they there or not? maybe I make sure I have them go upstairs step over step and come down step over step instead of that safety hang on to the rail and, 1 foot at a time. The other thing that I do with them is I'll get them to try and move fast. So I'll have them move faster or with things that are more automatic. Maybe I'm assuming they don't have movement in the arm, but if I give them something that requires a catch of balance or they have to use 2 hands to make it happen, I'll give them a chair and I might have to put it in their hands, but then I'll say, don't drop it. And so maybe then that's when I'll see, does the arm have some movement? So to go back to, therapists have to be creative. I think we just have to let our patients direct us to be creative. Don't make it so hard and don't make it so traditional. So that was just a little bit of an addition to the other question. Okay, so to your next one about how do you really start to set up the intervention? Again, I think if we have our top 2 or 3 impairments, 2 or 3 that we think we really need to treat first. I need to treat these first. Then I choose activities and the setup, the environment. And so I think you know what I mean by that. And I'm gonna, a little bit later, because one of the other questions was around the arm-leg connection. So I'm gonna bring up a few slides later and I'll bring this in together for you. But I think what we do is I use 3 things to treat impairments. So I have to know what those top 2 or 3 are. And then I manipulate 3 variables: the task, the environment, or what I call the setup, and then how I, the helper, and that in these days of the pandemic, it might be a family member doing it instead of us, but how do they start to, using these 3 things, we want to constrain or manipulate the environment so that we're more likely to get what we want. So I know my impairments and I know who the person is. And so then I start to pick subtasks that help me target those impairments with just about everything I'm doing within the session. So if I pick something, let's say someone is very interested in bike riding. And so I can choose which side of the bike do I have them on so that they have to be stopping it from tipping over or putting their foot up onto the pedal or walking and pushing it. If they have a leg that tends to kick out because they're not using their hamstrings, can I have them on the one specific side in this wobbly object so that I demand that their body move in a certain way? So the choice of the tasks and the choice of the environment can do a lot of work for us, especially during the pandemic time when our hands can't be doing as much for us, or skilled hands can't be doing as much for us. So I use something I call the triad that I'll put up on a little slide later. And I form my treatment choices. They all have to be targeting the most. I often will do a little challenge to myself where I think, okay, for example, let's say I think the hip extensors are very, very weak. So I make a choice in an activity that targets the hip extensors. Then I think, good, how many ways can I treat it within this little environment? Then I think, what's the second biggest impairment? Oh, the second biggest impairment might be that they don't sustain thoracic extensor activity. So then I look at the activities I've come up with, and then I see, can I change it a little bit to make sure I get the thoracic extensor piece as well? So I don't have to do separate ones for the hip extensors and separate one for the thoracic extensors. As I pick the activities based on the most important one, and then bring in that other one by manipulating my setup. So the objects are a little higher, they're a little farther, maybe they're a little heavier to get the thoracic extensors. So I call it layering. I keep bringing in the next impairment after I've got my top couple included in those activities. So that kind of gives you a starting point with that one.
Okay, thank you. And one point that calls my attention is taking into consideration what the patient wants.
Absolutely.
What does he desire? What does he want? What function does he want to improve? So that's really a great point you brought out. And also, this progression that has to be a challenge, but not too big for the patient, so that he doesn't disappoint or get tired. So that's a challenge for us to help to make this progression in a really smooth way, but that challenges the patient. Always try to improve his function or her function.
So always starting at the participation level of the ICF is to know who that person is. From there, so, you know, that I kind of talk about like a funnel. You know what a funnel is? Where who is that person gives me a whole bunch of choices. Then I think, well, what activities do they need to do? And that helps me start to narrow it down. And for some of our patients, picking the whole activity is too much. Can I pick some subtasks of it, a little piece of it? So back to the bike riding example, someone might tell me they want to ride a bike again, but they're not at a level where they can manage riding the bike. But could they at least stand and hold it and maybe check the air pressure of the tire? Or could they walk and push it? Could they put one foot on it? So you look for a subtask, but then you're engaging the individual in an enjoyable and a challenging way so that they're working towards their movement improving and their end goal. Your idea about challenging is right. I think a lot of times we're not trained in school to challenge our patients enough. We need to challenge them as much as we can, keeping it safe. And so I think most times therapists need to go harder with an activity rather than easier. But your next comment is true, is that let's say I'm asking them to, maybe the arm doesn't work so good. And so I'm asking them to, you know, can you go get your bike? Can you take your bike with both hands? Well, maybe they can't lift their arm onto the bike, but that's not the important part of the challenge. Maybe what I want them to do is hold the bike steady and now with their less involved foot, step to the pedal. So instead of saying, well, gee, I can't do that because they can't lift their arm onto the bike, well, I need to do that for them. It's okay to do pieces of movement for them if there's a benefit that you're trying to get in the next part of the task. So I'll put their hand on the bike. They might then be able to hold it, but they can't do the open chain piece to get it there. So we need as therapists to decide which part do we need to do or help with. It's reasonable so that we get what it is that we want from the other piece of it. I think that we have to make it possible, and then we need to challenge them within that range of possibilities. So I think therapists, we often think, no, they can't do that. No, they can't do that.
Right.
Well, they could if we could do a piece of it, and then we give them the challenge at the right time.
Mm-hmm. Of course. And I think we were formed that way, at least in my experience. Fill in the nose first. he can't. So be positive and start whatever the patient is able to manage, and then progress him. What I like from this approach, Cathy, is that we see the person as a whole. We were also treated as, we were also educated as to treat limbs or halves. So in this way, we really get the whole body involved in this part. Right. And that is also a challenge for us, because although sometimes we focus on the hand because we have to treat specifically something, an impairment in the hand, we still have to be the arm, have to see the arm connected to the trunk and the rest of the body and to the other side. So that leads me to my next question of this kinetic chain and the way to involve the two sides. We'll still talk about the involved side here, not the most involved. So thinking that the other one is all right. So could you give us some ideas on how to integrate the whole kinetic chain?
Yeah, I think that, again, we were trained in school, this therapist has this part of the body, this therapist has this part of the body, and it's so short-sighted. It really doesn't allow us to really help our patients as much as we could. I think a lot of times, I always say that sometimes your patient's biggest impairment to their leg function might be the arm. And sometimes your patient's biggest impairment to the arm might be the leg. For example, we see someone who, if they're sitting down, everything's nice, the arm can relax in their lap, but the second they go to stand up or the challenge on their feet gets greater, that's when we see that arm pull up. And
Right.
So I think that one of the most important things we need to do as therapists is determine what influence one is having on the other and which one is the problem. So, you know, the terms I use is we have to find the zig that causes the zag. And there's not always just one, there might be multiple ones. So it might be what they're doing with their arm or their leg or trunk might be a substitution because of the other one is the problem. So we see our patients, they use their trunks in, you know, this very effortful way, and it's to try to lift their arm up. Well, so the trunk, the problem might not be in the trunk and what they're doing in the trunk. It might be because simply, or they're using abduction at the shoulder because really what they're missing is flexion. And so again, that comes back to observations, is when I'm seeing something, I'm looking first at, well, why are they doing that? Why are they substituting? So I think asking that question is, why are they substituting, or what are they substituting, helps us find out those most significant impairments. So we have a more involved and a less involved side, but we also have an upper and a lower body. And I think a lot of times, especially as physiotherapists, is we get focused on the leg and we just want to get them on their feet. But unless we integrate the whole, we're never going to get their walking as good as we want as physiotherapists. As we have to integrate the arm, we have to integrate the head and neck, we have to integrate the trunk, and then the sensory motor visual into it. So I think working as that dynamic team, all members of the team really treating the whole body. We may still be, as PTs, we may still be the gait experts, but if we don't treat that arm, their gait might never get better as well. So I think I'm going to just see if I can share my, I got to find the option to share my screen with you. There we go. I'm going to just share my screen. You have to enable screen sharing, apparently. I'm getting a message to say that it's disabled. You know, it said host is disabled screen sharing. So if you're down at the bottom of your screen, see if there's something where you can allow me to share.
I think I'm ask Rosie because she's a host.
She's controlling it? Okay, so it might just be a little icon at the bottom.
Okay.
That she needs to just
Just give me a second, please.
You guys are going to edit this later, right?
Okay, she will do it.
Okay, she's going to take off. Okay. There we go. Okay. Oh, no, she needs to let me share my screen. She's got her screen, so she needs to, she's disabled my ability, so she's got to allow me to share. She figuring it out? Ah, perfect. Okay. Perfecto.
Good.
Okay. So tell me if you can see my screen now, Elvira.
I do. Mm-hmm.
Okay. So I won't spend lots of time on each one, but one of the things with the arm is, I'm just going to go to here, is what we've been very successful as physiotherapists to help the leg get better, because it has a job. We can't get very far if we don't put weight on two legs. But the arm, it's very easy to live in the world with only one arm. We've become so good in healthcare at making all kinds of equipment and adaptations to function as one arm. But really what we need to do is we need to give the arm what I call a serious job. So right here, not just an optional arm. So I call it making it be a necessity versus an accessory. So we really have to give the arm something that if it doesn't do it, there's a consequence. The object falls out, the person tips over, it might be something like that. So we've actively loaded the leg. So we've loaded the leg, but we put the arm away. And I always come back to the C in CIMT, so constraint-induced movement therapy, is that the C stands for constrained. And in the experiments, if you constrain an arm, you're not going to use it. Whereas if you force it or put it in a place where it's more likely to be active, you're going to have more success. So again, I'm not going to spend too much time, but I wanted to just sort of hit the highlights. So like you mentioned earlier, one of the first things we have to do is we have to reconnect the arm to the body. We have to make sure that the shoulder girdle is aligned and safe. You will never get normal movement with an abnormal alignment. So we need to first make it be reasonable, not perfect, just reasonable, a good starting point. So we have to get it into a safe, a better alignment, but then we have to work through that kinetic chain. So the lower level the arm is, the more likely we have to keep it at this closed chain or modified chain. Rarely can we get to open chain early on. We have to stick with closed chain and modified chain. Now, some postures are gonna help you. The other thing that I think I want to make sure that people understand is that the arm, you are going to get better activation of the arm, not in sitting. We've tended to take our patients back to sitting to treat the hand, to treat the shoulder. You're going to get much better responses when you get the person in standing if you can, but at least if you can't get them standing because there's too many pieces to hold together, then you have to go into quite higher sitting or higher sitting and forward bend where the arms are part of the surface, not in a damaging way, but on a surface that help be part of that stabilization support base. So it might be squat, and so you need to treat in that logical sequence. I'll come back to this point later, but I've just got some pictures here. Hopefully we can kind of go over them. So this is an example of this gentleman. If you look at his arm, and if you just first saw that, right away your focus would be on the arm, that, oh, we have to make that arm better. We have to make the arm better. But this is in the same session. If you look at how functional that arm is, this was a man that when I met him, sitting in a chair, he was moving both arms normally, talking to me, and I had a hard time picking out which side was the impaired side because he's talking and he's moving his arms around. And it wasn't until he stood up and started to move around that I thought, okay, his left side is his more involved side. So if I'm a therapist that treats arms, I'm going to try and treat this arm and say, oh yes, it has impairments. He's got a fisted hand. But if I sit him down and treat him in sitting, there's nothing for me to work on. I need to treat him on his feet. But what this showed me, going back to our observations, is his arm was substituting stability because his leg did not have the stability. And so that's that example of trying different activities and making those observations of when does something happen and why. So now if I've determined that his bigger impairments are in his leg, I can't leave his arm out of it and make his leg better. I have to give his arm a different job, not a holding, stabilizing job. I have to give it a different job to take it out of play. So now if it has to stabilize the ladder or the ladder here, then that means that he can't use it to stabilize his leg. And so now you can see the instability at his hip. I had to really work on his hip stability, hip and trunk stability, but with his arm holding a relatively unstable object. So I would call these two pictures down here, more of a closed chain to modified chain maybe. So giving it a stable place, he had an arm that definitely could be up at 90 degrees, but giving it a different job that's safe so that I could target the impairments. He certainly is the exception to the rule. He had an arm that could absolutely be over his head without me worrying about the integrity around his shoulder. So next this is definitely this far picture over here. This is what I would call modified chain. The ladder, he has to control the weight of it. It's in a different range, but now his arm has that job so that then I can really target the stability of his hip as he's having to move around. So it helped me focus on his hip and constrain the substitution that his arm was moving in. Here's another young man. So he had a hand, and if I was smart, I would have put in the other picture first, but his hand tends to be like this, very flexed, very curled. And so we had to first work on, let me get it in a very closed chain way. He was interested in computers. So actually, let me just pop back to here. So this gentleman was a handyman. He liked to fix things. So I'm going to work with objects in an environment that's related to what he likes to do. This guy, he was a computer technician, and he also loved football. So working within both of those tasks. So here, more in a closed chain below gravity, but he has to use it to stabilize. If he doesn't use it to stabilize, he's not able to manipulate where the computer is. So you start to give it a job that if he doesn't use the arm, then he's not going to be successful in doing whatever the task is. So that's a closed chain example. This one, now progressing him, this is modified chain, so his right arm again, and finding a surface that accommodates his tightness. It's because he had a very tight hand at first. But now he has to tip this bench out of the way because we're going to get ready to play football. So we're clearing the area for football. He has to tip the bench. So the use of a tipping surface that if he doesn't hold with both hands, it will tip back at him. So I use that concept of tipping objects or tipping the body. He's tipped as well. So here he has to use his arm as part of his base because his body weight is tipping onto it. So here now, modified chain, a little bit more advanced, is he has to hold the weight of this as we're tipping it to get ready to move. It's a two-arm, a bilateral task. It still allows us to work on his leg impairments as well. And then this third picture over here is still modified chain, but a little less stable. But if you look at how much stability he requires through his arm to be able to jump up high for the ball, it's showing that that little bit of stability and necessity is going to really help his arms. This gentleman, so he was a dog trainer for police dogs. And so at first, you see where I'm more closed chain. And this wasn't where I started in therapy with him. I started with his hand on a lower surface, but progressed to here to show. So now same thing, I'm giving his arm a job, but see how I'm helping it stay there. It's okay if you have to help it stay there, but he has to be active in his arm when I have him do a very challenging step up onto the stool to really target his left side impairments. So keeping the arm as part of the base, it's not always perfect. You have to find what works and then progress it to a modified chain task. So I had to help his hand form onto the chair. I might have even had to help it get to that height. And then he has to maintain it there while he's having to work through his arm. And then we have closer to open chain, back to what he would have to do for his dog training. job where you hold your arm out and the dog comes to jump there. So this is back to that triad I was talking about. So I have to know their most significant impairments. I have to pick the right task or the subtasks that are important to them and help me target the impairments. And then I pick my setup. What objects am I going to use? Where am I? How am I going to constrain the environment? And then when we have the option of getting our hands on, then I can use my hands to really help them. The other things that I was just thinking with that, I'm going to go through it, but so I talked about the fact that we have to help that hand stay connected. I think a lot of times as therapists is we think that the arm, if it's a very low functioning arm, we think that we can't use it on objects, but we have to be a little bit creative. We have to find ways for that arm to stay there. That's simply just stretchy material. So we call them walkers. I'm not sure if you call them walkers or frames, but instead of giving somebody a cane or a stick so that they become a unilateral walker, is maybe I need to really be creative and find a way to help even a very low functioning hand make contact with a bilateral object. So these are all walkers, but walkers. But I think of things like suitcases or wheelbarrows or other objects that bikes, so riding the bike. I'm gonna stop sharing my screen for a second and come back. Is I use simple things. So this is simply a little tensor wrap that if I had a sore wrist, sprained wrist, but I will attach my patient's hands to objects using this. It's just a little Velcro. So I'll attach it there. It could be some other little light strapping, stretchy, soft strapping. Maybe I attach it to the wheelbarrow. Maybe I attach it to that suitcase handle. And so, because if the hand doesn't have the function, I then assume I can't use that arm. But if I attach the hand, then I can still maybe get at the proximal shoulder girdle pieces. I can still work the glenohumeral flexors. I could still work the biceps or the triceps. So as long as you could connect the arm safely to an object, we need to do that. So safe is the key word, not up in great ranges if they can't manage it. But one of your questions was, how do we help? It's so hard to keep the arm connected. I think because we haven't kept it simple and we haven't looked at bilateral tasks where we might have to help it get there, but the demand of the task or that connecting the dots, if you know what I mean, is if I give them stability through the arms, it helps me get into the leg and the trunk. So just finding ways that are safe to keep the kinetic chain going, I think is critical. If I close the chain on the arm, I get all kinds of better activation, trunk and legs, and vice versa. Okay, I've said a lot of words, I'll stop.
Okay, well, thank you so much for sharing your clinical experiences with us. You're giving us a lot of practical ideas, and I think you're teaching us how to think out of the box and to be creative. And I think we need to do a lot of task analysis as well. Because
Absolutely.
if we don't do task analysis before all this, we'll be lost. Yeah. So thank you so much. It's been a great talk with really basic but fundamental activities. Closing the chain early in treatment and progressing from there on. Cathy, we're all facing new challenges with this new reality we're living. I know you have a great deal of experience in telehealth. How do you handle all this with a family member? How do you do this on the distance? We're all having to reinvent ourselves. How do you do that? Share with us a little bit of your experience.
Well, I think one of the things when I started off, as I said, keep it simple. And I think that's a big part of it is if I'm only able to connect with someone through the screen And so the family member, the friend is now the therapist. I think that just like we need to keep it simple when we're the therapist, we need to stop thinking so complicated, is I try to guide the family members or the patient themselves, if they're able to do it, to keep it simple. I have them focus on only one or two things at a time. And those have to be things that are important. So what are those key impairments? So it might be this week, let's really focus on the shoulder flexors, or let's really focus on the hip extensors, whatever it is. And so I give them very simple activities that are part of their functional life. So not exercises, not traditional therapy exercises. So it might be something like when they stand up throughout their day, is where are their feet going to be when they do it, so that I can bias the weight more to that one leg versus the other. Maybe it's that with their arm is I find out what they're doing in their day, what is their typical day like, and I give them ideas of where that arm could be. So where the arm, instead of, on their lap, could it be on a surface while they're reaching up with the other side? So I try and find one or two key things, don't overwhelm them, and have them focus on that, but have them be part of their functional routine. So not traditional exercise, but part of the functional routine. The other thing I try and assure them is that it doesn't have to be perfect. It just has to be good enough. One of the things that we know from research is that our patients are not practicing movement enough. They're not getting enough repetitions. Mm-hmm. If we could simply increase the number of repetitions our patients get of better movement, not perfect, but better. So instead of the wrong thing, can it be just a little bit better? If we can increase the number of repetitions our patients get, they'll get better. And so that doesn't happen in my sessions, even when I can put their hands on, is that's not enough repetition. They need to do that on their own time anyways. So I try and just give them some very simple ideas, and I'll demonstrate, and I'll have them demonstrate, and the family member will, show it to me on the video, and we, try and refine it a little bit. But it just needs to be good enough, and it needs to be something that happens frequently enough through their day. Simple, doesn't require equipment or equipment that they wouldn't already have around. So the right height chair, or, hooking their hand onto, something that they tend at the kitchen counter or out in the yard, or, wherever they might be, is just keeping it super simple and not putting huge expectations that they have to do all these different things. So super simple.
Well, thank you. Very, very important key points on the new approach. Next, thanks to the technology.
That's right.
What would be your message to the families, Cathy?
Families around telehealth, or around recovery expectations?
Or in general, to a family whose a member is been through one of these movement disorders or pathology or conditions.
Mm-hmm. So I don't like to put too much pressure on the family members for them to be the therapist or to take that responsibility. So that's when I come back to that triad of, could they even just change the setup for where the movement happens? Maybe it's around a dressing task. Maybe it's around eating. Maybe it's around, the yard if they like to garden. Is, can the family member, if the patient needs help, can they even just create a setup that might bias the person more towards using that arm, or standing better on the leg, or where the objects are? So that they don't have to feel like they have to be hands-on. Maybe they're just that reminder. Maybe they're the ones who, create the set, and then the patient is the one who's just doing the movement within it, so that it doesn't require a lot of time, it doesn't require a lot of hands-on. And so that's back to one or two key things, as I give them a few ideas, and then say, okay, work on that for this week, and then we'll see how you're going. But I try not to, with the family members, make them feel responsible for taking my role or, being a therapist. But I really try to, the word is empower, but I want them to know that they can be very helpful in helping the patient get better, that they should expect recovery, that their loved one will absolutely get better, and there's no time limit. That's one of the messages. I think, unfortunately, patients and families are still told that recovery can only happen for a certain amount of time. And we know that's not true. That is just so wrong. We know that neuroplasticity can continue to improve for a very long, long time. I had a conversation with a colleague the other day. She's treating a young woman, 30-some years old, who had her stroke when she was 8 months pregnant. And she was, so she had a brand new baby to go home with. And she was told after 6 months, your arm's not going to get better, give up on it. Well, this woman is now about 3 years post. Her little baby's about 3 years. And the therapist working with her is someone like you who knows better, who knows that recovery can happen forever. And so this young woman's arm is getting better and better and better, just keeps getting better, because she hasn't given up on it. She's put it into tasks where it has to work, that consequence, giving it a job, and the arm is just slowly getting better. And she's now able to get down onto the ground to play with her little one, get back up from the ground, use 2 arms to push the stroller. And so I think that we have to give that message to our patients and families. Don't give up. It takes time and it takes hard work, but just keep steady at it, slow and steady, and don't put the pressure on them that they have to be the ones who make that recovery get better. The patient's the one who has to practice. All we do is support that practice, really.
That's right. And brain's amazing.
It is. It's amazing.
Well, one of the key takeaway messages that I stay with is that keep it simple.
Yes.
You said that so many times, and that's a great learning for me. And I hope for our audience too.
In English, I'm not sure if you know this one, but so KISS, the word KISS, K-I-S-S, we call it the KISS principle. So keep it simple.
Okay.
And the second S is for stupid. Keep it simple, stupid. So stupido. So you don't have to add that part, but I just think I use the KISS principle, really just super simplify it. Not to the point that it's not successful, but that it can't be anything but successful if you keep it simple.
Well, I didn't know that one. I'll catch it up.
There you go.
Cathy, I don't want to take more of your time. Thank you very, very much for your generosity, for sharing your experience, all your clinical cases. It's been very, very valuable for us. You've given us many, many practical ideas. I wish we could be together, but maybe we hope to have you in the near future, or find other ways to keep sharing the information and to improve our level of quality here in Mexico. I'm sure we're on the right track. Is there any last message that you would like to give us?
I think just that, I think as therapists, we have to be detectives. We have to be detectives where we really have to, you have to find what those most significant impairments are, or any treatment you're going to give is not going to be effective. So you can be the most creative, have all kinds of great treatment ideas, but if you're not treating the right thing, you're not really helping your patient. And so I think it's always worth the time to slow down and to take your time to figure out those most significant impairments. So again, if this pandemic is going to help us in any way as therapists, it's because we can't get in there too quickly and right away start to mess things up in the wrong way. It's making us observe much more and having to figure things out. So you have to really get to the most significant impairment, or you're only going to delay recovery and maybe never get there. So my advice would be for therapists to keep working really hard to make sure they have the most significant impairments. And they'll know if they do, because if they treat them even a little bit, they should see the potential right away. It might not stick until you have enough repetition, but if you can start to influence movement very quickly, you've made the right guess. You've guessed well. If you're not making them better, then you have to go back and you have to look again until you figure out those most significant impairments. So that's the most important piece, I think.
Okay, well, analysis, function, observation, I think very important messages for us. Cathy, thank you again. It was a great pleasure to get in touch with you now in this new way. Yeah. We appreciate your time, your expertise, and your generosity.
De nada.
And to everyone who join us here, thank you very much. Gracias a todos por estar con nosotros y estaremos atentos a nuevas participaciones de Cathy. Muchas gracias, Cathy.
And Elvira, please feel free to share my email address with people if they're wanting to contact me in any way. And maybe a future session is if people have little video clips and we could do some analysis together. You know, with a live Zoom room, you could translate for us. That might be a useful future meeting.
Okay, fantastic. Thank you very much again.